Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our great fortune is to have a new speaker with us, Dr. Kaleb Abbott, who's going to talk about differentiating dry eye from trigeminal disorders. He's assistant professor at University of Colorado School of Medicine. He's a faculty member of the Dry Eye Clinic and the Center for Ocular Inflammation, where he specializes in complex ocular surface disease and contributes to clinical trials and research in this field. He also serves on the board of directors of the Ocular Wellness and Nutrition Society and is the vice chair of the Nutrition, Disease Prevention, and Wellness Special Interest Group for the American Academy of Optometry. He also contributes to the American Medical Center Optometry AAO-SIG Advisory Council. He has had numerous recognitions, and most recently, he was named What to Watch by Modern Optometry. So with that, please, nice warm OEC welcome for Dr. Kaleb Abbott. Please take it away.
Thanks, Joe. Yeah, so like Joe said, I'm an assistant professor at the University of Colorado School of Medicine. I'm about 75% in the clinic and 25% doing clinical trial research and epidemiological research. So most of the time I'm in the trenches seeing complex dry eye cases, as we're a tertiary referral site for all of Colorado and surrounding states as well. And today we're going to discuss probably what is my favorite topic. And this is really a topic all about the discrepancy that we see between dry eye signs and dry eye symptoms. And this is something that really is frustrating to a lot of providers. We're going to go over that today. So these are my disclosures, all of which have been mitigated. So when we think about the history of dry eye, it really all starts with Sjogren's syndrome. We thought that dry eye was as simple as there's an autoimmune condition attacking the lacrimal glands. Lacrimal glands stop producing tears like they should. Eyes dry bad, put a drop in the eye, eyes not dry anymore, we're good. And we thought that it was really that simple. But then all of a sudden, people started to report that their eyes felt dry. But then upon examination, these patients didn't actually have dry eye, despite their eyes feeling dry. So this left researchers and clinicians pretty perplexed. What is actually going on here? So we started to get fancy. We tried to look at all different metrics for dry eye, for tear film analysis, for MGD, things like that. We looked at abnormal tear film health, so tear breakup time, and inflammatory biomarkers in the tear film, matrix metalloproteinase 9, tear osmolarity or salt content in the tears. We started looking at things like lid margin disease and anterior blepharitis, posterior blepharitis, meibomian gland dysfunction. We even broke down meibomian gland dysfunction into many different causes and obstructive, and if it's associated with microbes and things like that. But all of these metrics still didn't correlate at all with the dry eye symptoms that our patients were experiencing, which is, again, quite frustrating for providers and for patients. And I think that when we think about dry eye, we're typically grouping it under the umbrella of, are there signs and are there symptoms? And we say there's either signs of dry eye or there's no signs of dry eye. And then we say that in terms of symptoms, we have symptoms of comfort, and then we have visual symptoms. And then based off that, we say either that there's dry eye or that there's no dry eye. But I argue that if you really try to think of it just in this black and white framework, that it's going to drive you crazy, and it's going to be to the detriment to you as a provider and to your patients. So do we understand dry eye at all? Because we don't have a single objective test that can actually and accurately predict our patient's symptoms. And if we do understand dry eye, then how do we explain this? This is the treatment discontinuation rate at 12 months. We see that when we prescribe things to our patients, over 70% of the time at that 12-month mark, they're not taking it any longer. And only 13% of patients actually feel that their dry eye is adequately managed. So I'd say that overall, we're not doing a very good job when it comes to dry eye. And I think it's because we don't have a great framework for how to think about it. So our corneal nerves, the missing link. So we have over 7,000 nerve endings per square millimeter in the cornea. This makes our cornea 300 to 600 times more sensitive than the skin. And our cornea is avascular. So it's actually depending on the trophic support from the nerves and from the tear film itself to derive its nutrition. So without proper nerve function, our corneas cannot function at all. So we're going to start by going into some basic corneal nerve anatomy to give us a framework here. So when it comes to the innervation of the cornea, it really starts with the trigeminal nerve nuclei, then the ophthalmic branch of the trigeminal nerve, to the nasociliary nerves, long ciliary nerves, and finally to the corneal nerves. Once these nerves reach the cornea, they enter radially, essentially right around where the limbus is. 1 to 2 millimeters into the cornea, they're going to lose their myelin sheath, but keep their Schwann cells. Then they travel anteriorly through the cornea, where they eventually form a plexiform network in the anterior 1/3 of the stroma. And we call this the subbasal nerve plexus. This is something that we can't actually visualize with a slit lamp, but at the University of Colorado, we have access to a confocal microscope. So we can zoom in 600x onto those corneal nerves, and we can actually look for structural changes into the corneal nerves. So this is very, very small, something that we don't actually see. But this plexiform network, or the subbasal nerve plexus, is what is providing that trophic support to the whole anterior portion of the cornea, in particular, the epithelial cells. So then from that subbasal nerve plexus, the axons continue to go vertically and anteriorly. They lose their Schwann cell sheath. They enter the epithelium, turn 90 degrees, and they are actually going to course between basal cells. And we have two different types of fiber types that are located within the corneal nervous system. We have A fibers, which are myelinated straight nerves. They have a large diameter. And then we have C fiber types, which are smaller. They're beaded. They do not have myelination. And C fibers are comprising the majority of that subbasal nerve plexus. These are also the fiber types that become free nerve endings and are really responsible for sensing a lot of the pain that our patients are experiencing with their dry eye. And then it gets a little more complicated in that we have different nociceptor types. So nociceptors, also called sensory neurons or pain receptors. We have three different types located in the corneal nerves. The polymodal, which comprises 70% of the nociceptors or pain receptors. These are associated with A and C fibers, and they detect a whole variety of stimuli. So mechanical stimuli, chemical, heat, osmolarity, things like that. Then 20% of our pain receptors or nociceptors are the mechanonociceptors. These are only associated with A fibers, and they're sensing an acute pain to touch. So when we're doing something like testing corneal nerve sensitivity and kind of lightly touching the front of the eye, we're testing those mechanonociceptors. When our patients have an eyelash or trichiasis that's hitting them in the cornea, it's the mechanonociceptors that are primarily responsible for detecting that. And then the most interesting one is the cold thermoreceptor. This only comprises about 10% of the nociceptors, but this one is very unique in that the cold thermoreceptor is not actually a true nociceptor, in that it doesn't actually convey any signals for pain. It's associated with A and C fibers, but instead of trying to send signals for pain, what it's trying to do is actually detect surface wetness of the eye. So it's detecting a relative cooling of the cornea and tear osmolarity. So when we think about the tear film is warm and it's coating our cornea. As our tears begin to evaporate, it causes a relative cooling effect onto the cornea. When you reach a certain threshold, say 1 to 2 degrees of cooling, the nociceptors on the corneal nerves, the cold thermoreceptors, will start to fire in response to detecting that temperature change. And also, as our tears begin to evaporate, you get an increase in salt content in the tears because you're having less fluid and the salt is what's left over. So that spikes our tear osmolarity. We know that we can get tear osmolarities focally in the cornea, as high as 600 or 700, even though generally when we're testing it in clinic, anything above 300 is considered abnormal. In different portions of the cornea, it can go much, much, much higher than that. And that's going to set off those cold thermoreceptors to fire. When those cold thermoreceptors fire, it's actually telling your lacrimal gland that it needs to secrete more basal tears. So not reflex tears, but actually increase the amount of basal tear production. There's also potentially a silent nociceptor that we're still learning more about that only responds to inflammation. And then each of these nociceptors actually have specific ion channels that they use. So some of these ion channels are called transient receptor potential ion channels or TRP channels. These are located throughout your entire body. So you've got some in the nervous system, you've got some on epithelial tissue, you've got some, in your muscles, in skeletal tissue, and all of your organs. And these are the different subfamilies of these ion channels that are located in tissues throughout the whole body. But we also have these ion channels in the corneal nerves, in particular in the nociceptors or pain receptors of those corneal nerves. Now, when we think about these ion channels, we have them located throughout our entire eye, including the retina, lens, uvea. But pertaining to today's talk, we're going to talk about ones located in the cornea, the corneal nerves, the conjunctiva, and the eyelids, because that's truly what's driving symptomology in our dry eye patients. But when we think about what's happening with some of these other ion channels throughout the rest of the eyes, a dysfunction of certain ion channels can lead to disease. So, for instance, if you have a genetic mutation of certain ion channels in the retina, that can lead to a macular degeneration. Or if you have certain genetic mutations affecting ion channels in the uvea, it can lead to a uveal melanoma. So, specific ion channels associated with those pain receptors or nociceptors of the cornea, we're going to go over 4 today. So the first one is TRPV1. This is an ion channel that's associated with the polymodal nociceptors, and it plays a key role in dry eye symptoms. So the majority of the time that our patients are experiencing symptoms of dry eye, it's stimulating the polymodal nociceptors because that's the predominant nociceptor of the cornea. And specifically, it's probably being stimulated by the TRPV1 ion channel of those polymodal nociceptors. So it plays a key role in dry eye symptoms. It also promotes inflammatory mediators and peripheral sensitization. So if TRPV1, that ion channel of the nociceptors, the polymodal ones, continue to be stimulated over and over and over again, this is going to lead to inflammation developing in the ocular surface and in the tear film. And if the TRPV1 ion channel continues to be stimulated over and over and over again for a long time, it can lead to a peripheral sensitization, or something that we like to call neuropathic corneal pain. So the nerves start to become hypersensitive. Then we have the TRPA1 ion channel. We don't know much about this ion channel. We know it's associated with those polymodal pain receptors. We think it plays a role in neurogenic inflammation and allergic inflammation as well, but we don't know much about that one. Then we have
Kaleb, do me a favor. Go
Yes.
back. Can you just go back one slide? Now
Yeah.
you have this picture here, this bilayer. Is this like is this like a epithelial cell that we're looking at in the bilayer membrane, and these are the corneal nerves infiltrating it? Help me out with this picture here.
This picture itself isn't depicting ion channels of the sensory nerves of the cornea. This is trying to just depict ion channels in general and how they're working. So it's essentially an ion channel that's letting passage into cells or into sensory neurons.
Perfect.
But this one's not specific to corneal nerves.
Okay. All right. Perfect. Thanks.
And then we have Pazeo ion channels and tryptamate ion channels. Now, the Pazeo ion channels are present in your corneal epithelium, the corneal nerves, and in the optic nerve. And this is actually a baroreceptor. So it's trying to detect pressure changes. So that's why it's located in the optic nerve. Obviously, your optic nerve is sensitive to pressure changes, and that is going to play a role in glaucoma. But these are associated with the mechanonociceptors of the corneal nerves. So ones that are detecting physical touch. But probably aside from TRPV1, tryptamate is the one that we need to know probably the next most about. And this is because it's associated with cold thermoreceptors. Remember those thermoreceptors or pain receptors that are not conveying senses of pain, but trying to actually detect surface wetness to determine the amount of tears that need to be secreted. So the tryptamate ion channel is responding and firing in response to tear film evaporation and hyperosmolarity. It's also triggered by cold weather as the tears begin to evaporate, and menthol as well. And when it's stimulated, it's going to increase your basal tear secretions. Now, there's some thought that we're beginning to think about that it's possible that some dry eye could actually be a TRP channel dysfunction. So channelopathies are recognized throughout really all of medicine as being causes of different disease states. So my wife is a pediatric neurologist, and she specializes in epilepsy. And a lot of what's going on with epilepsy is that specific ion channels throughout the whole body aren't working well. So they have certain drugs that they use that are targeting sodium channels, or that are targeting calcium channels, or things like this. And some of them actually are TRP channels. And so you're developing drugs that are trying to target those specific channels. When it comes to dry eye, it's very possible that we can get a dysfunction of these channels over time, or we can be born with a dysfunction of these channels that influences symptomology, but also influences things like tear secretions. We also can get functional changes of these ion channels with age, but we need proper expression of these ion channels to maintain ocular surface and tear film homeostasis. So there's one drug that's going to be expecting to get FDA approval in May of this year, and this is a TRPM8 agonist. So it's trying to actually stimulate the cold thermoreceptors through that TRPM8 ion channel. And if you could successfully do that, you should be able to increase basal tear secretions. It should provide a cooling sensation upon instillation because it's not actually conveying a sense of pain, and could potentially restore proper cold thermoreceptor function in aging individuals. There's some other drugs that may be coming out. So this is an example of one that is a TRPV1 antagonist. Remember, TRPV1 is the ion channel associated with polymodal nociceptors, and it's driving most of the symptomology in our dry eye patients. It also leads to inflammation. So this is a TRPV1 antagonist. So theoretically, this could be used for something like postoperative pain and discomfort after a surgery. And that's exactly what this study here was looking at. And then this is a drug that I was actually a part of the phase 3 clinical trials for. This is a drug that's trying to inhibit the synthesis of the TRPV1 ion channel. So instead of antagonizing that ion channel, you're trying to actually have less of that ion channel actually being made. If you have less of the ion channel, then you can theoretically decrease pain and decrease inflammation and things like that. But this unfortunately did not meet the primary endpoints in the phase 3 clinical trial for Sjogren's, which is the clinical trial that we were involved with this drug. So this brings us to our first question here. So our first question is, which TRP ion channel is linked with cold thermoreceptors and when activated increases basal tear secretions?
So just so you know, the polling question is open. For those who this is their first polling question, if you look at your screen, you'll see chat, you'll see polls. Go ahead and find the polling question and start responding. And we have answers rolling in. Joe, any questions that have rolled into this point?
There have been none.
I don't know if that's a good or bad thing.
Well, they'll start coming. This is I like the what'd you call them? Channelopathies? Is that what you?
Yeah, channelopathies. That's a term we're not very familiar with in eye care. It's a term that other medical specialties are very familiar with. Like in neurology, especially cardiology, things like that. In eye care, retina is probably the most familiar with channelopathies because we know that there's a lot of inherited retinal diseases that are genetic mutations affecting ion channels. Like Leber's congenital amaurosis is one. Retinitis pigmentosa, some types of it are associated with ion channels, congenital night blindness, conditions like that.
So we're getting down to kind of what we learned about, I guess, in physiology, where we're talking about the cell membrane and allowing the sodium, potassium, and all those different types of channels, right?
Yes.
Within the cell membrane. And if they're just not functioning properly, then you're not allowing things in and out of the cell and action potentials and all that fun stuff. Is that where you are in this?
Yes. Okay. Yeah, and primarily in the context of this talk, we're talking about, action potentials leading to the firing of specific nociceptors or pain receptors that are triggering symptoms or inflammation.
Kaleb, before we finish with the poll, a question did roll in. How are these medications that are under study the same or different than Restasis or Xiidra?
Yeah, that's a great question. I mean, Restasis and Xiidra are targeting inflammation. They're targeting inflammation specifically through the T cell pathways, whereas something like TRPV1 that's constantly stimulated, so that ion channel, which is part of the polymodal nociceptors, that's really starting with the far upstream inflammation. So where a lot of that inflammation is starting, and then some downstream effects of that are going to be, the T cells getting activated, and then them activating antigen presenting cells and a lot of inflammatory biomarkers being released at that point. So when we talk about cyclosporin or lifitegrast, they're acting on T cells trying to prevent the inflammation associated with them. Whereas when we're talking about ion channels and drugs targeting that, we're really targeting a little more symptoms, like decreasing pain directly by not letting the nerves fire. And we're targeting, overstimulation of those nerves
Mhm.
and associated inflammation with that. So I'd probably say inflammation wise, it's probably further upstream, but it's more directly targeting the nerves and symptoms.
And when you're using those medications, you're kind of taking an assumption, like let's say for lifitegrast, since you brought that one up, is that there is an overexpression of that ICAM molecule, and then that ICAM molecule being overexpressed on the cell surface then plugs into that T cell. So you're kind of making
Yes.
an assumption that every dry eye has an overexpression of ICAM that's plugging into this T cells, causing that inflammation. So this is kind of, I love it that you're explaining it's two different types of pathways here. Further, inflammation much further downstream or upstream as opposed to this. So that's very cool. All right. So with your being said here, your polling question, you had 24% saying trip V1, then you had trip VA1 at 18%. Pizeo was 6%, but if we were phoning the audience, I think 54% got that trip M8 out there for the correct answer. So.
Good. Yeah, trip M8's one that we should all probably start to be familiar with, because there will be a drug probably coming out later this year, our first drug that's actually targeting that ion channel. So to kind of recap a little bit, TRPV1 is associated with the polymodal pain receptors. It drives a lot of dry eye symptoms. We don't know a lot about TRPA1. Pizeo is associated with the mechanonociceptors detecting physical touch, and TRPM8 is a nociceptor that actually doesn't convey pain, but is responsible for detecting wetness and stimulating basal tear secretions.
So just
All
kind
right.
of go back to just a recap with the drug part is that this, like you said, T cells, cyclosporin, lifitegrast, and then jumping over to this is a whole new kind of mechanism of action
Oh yeah,
going after
completely
those,
different.
those channelopathies. I love it,
Yes.
and I'm geeking out because I love to speak in pharmacology. So,
All
And
right, now
Caleb,
we're going to go over some. Yeah.
another question came in. How are these trip ion channels measured or assessed?
How are they measured or assessed? I don't know if I have a good answer to that. I mean, we
Okay,
know, I mean, in like animal models, we can see how they're, what is stimulates them. And then, yeah, we can develop drugs to actually target them. But I don't know if there's a drug that, I don't know if there's studies that are actually showing like that you're physically, the drug is physically actually causing less stimulation of it, or if it's mainly looking at the downstream effects of, what you hypothesize should happen when you antagonize it, or if you give it an agonist. So that's a good question. Not 100% sure. So now we'll go to corneal nerve physiology. So when we think about the functions of the corneal nerves, we're constantly thinking about the sensory components, blink reflex, tear secretions, but we don't oftentimes think about the trophic function of the corneal nerves. This is what I want to bring to everyone's attention tonight. So our sensory nerves do more than just detect, things like there's something in the eye. Our corneal sensory nerves are releasing certain neuromediators that are actually trying to support your epithelial cells. So they're providing support to the epithelial cells, helping them properly turn over. So when you get an epithelial abrasion, the nerves are trying to help support that and help it actually heal. The epithelial cells in turn are releasing neuropeptides and certain factors, specifically nerve growth factor, that's actually then supporting the sensory nerves. So your corneal nerves are supporting your epithelial cells are supporting the nerves. The nerves are also telling the lacrimal gland to secrete tears. In your aqueous portion of your tear film, there's over 2,000 unique proteins. There's vitamins, minerals, nutrients, nerve growth factor, lactoferrin, lysozymes, fibronectin, all sorts of things that are supposed to nourish the ocular surface that is predominantly avascular when we're thinking, about the cornea. So it's depending on the tear film and the nerves for trophic support. So nerves help epithelial cells help nerves tell lacrimal glands to secrete, and the lacrimal gland secretions help the sensory nerves and the epithelial cells. So there's a lot that's going on here. And if one portion of this gets disrupted, then all of a sudden it's now impacting dry eye, it's impacting the tear film and the ocular surface homeostasis. So with all this going on, why do we not actually think about the corneal nerves? I think it's because we don't really see them. Outside of seeing a prominent stromal nerve like that, we don't really see the nerves very often. So I think we forget about their role in maintaining ocular surface homeostasis. So this is a picture here kind of depicting the whole pathways that we see. So on the far left side, you're seeing the ion channels. And then next to that, kind of the little bulbs that you're seeing is those nociceptors or pain receptors. And we're talking about the first order neurons on the eye. But then it does go down all the way to the second order neurons, which is really in the level of the neck, like the C1 and C2 spine. And this is from there that we can actually get something called, cervicogenic eye pain, where you're actually getting pain of the eye, but it's really being triggered by a problem in the neck, perhaps compression of the nerve in the neck. And then it goes all the way up to the third order neurons in the thalamus. And patients' dry eye symptoms don't just have to be from the eye. It can be anywhere along that nervous system pathway that's triggering their pain, which is something important for us to realize.
So hey, Kaleb, is it a true statement then? I mean, just kind of the irony of what you just said is that, we hardly think about the corneal nerves, but isn't the cornea the most innervated per capita part of the body? I mean,
yes, it is the most innervated tissue. So when something goes wrong, we feel it a lot. That's why I've had patients that say that, their corneal abrasion was worse than childbirth because it causes a whole lot of pain. But yeah, ironically, it doesn't have to be. You can get eye pain, from other portions along the nerve, like in the neck area too.
Yeah. Okay, cool.
So to understand dry eye symptoms, we really have to understand different types of pain, in my opinion. So we have to understand different symptoms our patients can have. So they can have dryness, they can have burning, they can have sandiness or grittiness and sharp stinging type pain. And pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such. So there's different pain origins, and we're going to discuss 3 tonight: nociceptive, neuropathic, and nociplastic. So nociceptive pain is what we actually traditionally are thinking about when it comes to dry eye. This is pain that's arising from an actual or threatened damage to the body, and this is due to the activation of those nociceptors that we just talked about. So in this picture, you see a nail that's going through the skin. If it goes through the skin, you're going to feel all sorts of pain that is coming from the nociceptors. But even if that nail was just lightly, or I guess maybe not lightly, but pushing on the skin, you would still feel pain from that. And you'd feel pain because it's still activating those nociceptors because the tissue is being threatened. So this pain should be transient in nature. It's associated with things like acute trauma, surgery, tissue inflammation. But then we have neuropathic pain. This is pain caused by a lesion or a disease of the somatosensory nervous system or central nervous system. This is when the nerves are becoming hypersensitive. This can happen in the peripheral nervous system or more in the central nervous system. Examples of this are diabetic neuropathies, so where you get painful hands and feet. You can also get the same thing in diabetics where it's causing pain in the eye. And then you can get post-herpetic neuralgias after like a herpes zoster infection, the residual pain that's left over even after everything is recovered. And then chronic post-operative pain as well. Then there's nociplastic pain, which is the most confusing of all of them. This is pain despite no activation of the pain receptors and no evidence of a disease or lesion in the nervous system. So this is really a dysfunction of the central nervous system or the pain processing centers of the brain. Examples of this is like fibromyalgia, chronic fatigue syndrome, irritable bowel syndrome, things like that. So when we're thinking about different types of pain and nociceptive pain, so we have things like Sjogren's syndrome, ocular rosacea, glaucoma drops irritating the eyes, and then anatomical, changes happening like trichiasis. That's going to trigger nociceptive pain. Then we can have peripheral sensitization, where it could happen after a LASIK or a cataract surgery, or chronic ocular surface inflammation can sensitize those corneal nerves and trigger pain. Then we can have central sensitization, which is like chronic pain syndromes, fibromyalgia, migraines, traumatic brain injuries, things like that. One problem, though, is that if it starts with nociceptive pain and we don't adequately treat it, nociceptive pain can turn into peripheral sensitization, probably through that TRPV1 ion channel. And then peripheral sensitization can actually turn into central sensitization if it's not adequately treated. So there's cases that we see in our dry eye clinic that it started off as maybe Sjogren's, but by the time you got the Sjogren's under control, it had already led to a neuropathic corneal pain or a central neuropathic pain. And that's when it gets very, very difficult to treat. but also gets a little more confusing than this. Let's say you have a neurotrophic keratitis, so those nerves are not working very well. You can actually get conversion of fiber types. You can get conversion of those A fiber types to C fiber types. So the A types are detecting physical touch, but the C is conveying senses of pain. So you can actually get neuropathic pain in the setting of neurotrophic keratitis, where you're not actually feeling anything on the eye, but the nerves continue to misfire. So you're constantly in pain. And this can kind of explain why patients that eyes look like this, they'll say, well, my eyes hurt. You say, well, that makes sense. Then a patient like this could say, well, my eyes hurt too. And you say, well, that doesn't make sense. And the top is nociceptive pain. The bottom is more neuropathic pain. Also explains how you can have patients that their eyes look like this, and they say, well, my eyes feel great. And that is more of a neurotrophic keratitis. Those nerves are not working well, and they're not telling the brain that the patient's eyes should be causing pain. So this leads us to poll question 2. What type of pain describes a lesion or disease affecting the somatosensory nervous system?
And as that question is rolling in, Caleb, I'll have Joe check to see if there's any polling questions, but can you just go back a couple slides to the corneas? And maybe the one before that. That polling question is, yeah. And just go, I mean, this is so fascinating. It's so cool. My eyes hurt. That makes sense. That's your nociceptive pain, but you got that healed cornea. I mean, you went through that quick, but which is fine. I know you're used to giving it, but I think this is so useful for our audience that, how's that patient come in with, no staining, and they say their eyes pain, that's their neuropathic pain that's there. So it just,
and those are the cases that it confuses them as providers. The provider tells the patient you don't have any dry eye, you shouldn't be in pain, and then the patient gets very upset. So, or it's also the case that, you start prescribing things for this patient because you're trying to treat the symptoms, but what are you actually treating? Like if you're going to prescribe cyclosporin or lifitegrast to this patient, what are you trying to accomplish in that case? So we're going to go over more of that in a bit.
Yeah, so I just thought this was just so cool, all the different, the different ways. So your polling questions rolling in nicely here. I'll display the answer. Which type of pain describes a lesion decrease affecting the somosensory nervous system? You had 45% going nociceptive pain, neuropathic pain 46%, and you have nocioplastic pain at 9%. So you got a kind of a tie there between A and B. So
that's surprising. Yeah, so nociceptive pain is something that is stimulating those the nerves. So it's something that's actually triggering dry eye. We would call dry eye nociceptive pain. So something that's actually stimulating those corneal nerves. Whereas neuropathic pain is when there's a disease of the nervous system that is triggering the pain. So it's not actually dry eye stimulating the pain, but it's a problem with the actual nervous system itself. So the answer in this case would be B. And this can happen peripherally, and it can also happen centrally as well. We'll go a little bit more. We'll do a deeper dive into neuropathic pain in a bit.
Okay.
So all this says that signs in dry eye do not equal symptoms. So we have to start considering the corneal nerves when we're treating dry eye. So this is the way that I like to think about dry eye. I don't think I have a pointer available here.
You do. You can see it.
I do. Oh, perfect. Okay.
You can see your pointer.
So I have pain status here on the y-axis. So bad in this, so red is bad in this, and green is good. So with pain status on the y-axis, anything at the top is going to be painful. Anything at the bottom is not a lot of pain. Then we have ocular surface disease status or ocular surface status. So think like corneal staining. So red is bad, so that would be corneal staining, and green is good, so no corneal staining. And what we see is that up in this corner here, we have dry eye. This makes sense here because our eyes are uncomfortable and there's corneal staining. So that's quote unquote dry eye. Then we have no dry eye, where our patients do not have any symptoms and they don't have any corneal staining. So that makes sense. But this is where most of us stop. We don't think beyond this. But we have neurotrophic keratitis, where our pain status is good. So our patients aren't really feeling anything, but our ocular surface status is bad. So our patients are having corneal staining present. Then we have neuropathic pain, where our pain status is bad. So the patients are feeling lots of symptoms, but the ocular surface status is fine. So that would be a case of neuropathic pain. The problem is when our patients come in to our office, we have no idea where they're lying on this spectrum. We don't know if they're dry eye, neurotrophic, neuropathic, or no dry eye. And it's our job as providers to try to figure this out. So what predicts whether or not our patients are going to be experiencing symptoms of dry eye? Interestingly, the top 5 that are listed there are the top predictors as to whether or not our dry eye patient is going to be feeling dry eye. The presence of chronic pain syndromes, anxiety, depression, psychiatric disorders, sleep disorders, and stress, more than the next 5 that's listed there. So dry eye is incredibly associated with depression and anxiety. I give a whole talk just on that one topic. It's associated with poor perceived health status. You can have patients in their 20s that come in, nothing is wrong with them, but they feel like their lives are falling apart, that they're super sick, that their bodies are falling apart, that their eyes hurt. It's very associated with sleep disorders too. I give a whole other talk just on dry eye and sleep and how one impacts the other. So we do know that in asymptomatic versus symptomatic dry eye patients, that scores for depression and anxiety are significantly worse in the symptomatic group. And then we also know that treating dry eye reduces anxiety and depression levels, and treatment of anxiety and depression actually improves the success of dry eye treatments. This is contrary to what we're taught in school. We're taught in school that if you use anxiolytics or anything to treat anxiety and depression, it decreases lacrimal gland secretions. It's going to cause dry eye. But the research tells us that the treatment of anxiety and depression actually improves the success of our dry eye treatments. And that's because there's a lot more to it than just lacrimal gland secretions that we're talking about. We're talking about the overall sensitization of the nervous system in general. So it's a lot more complex than I think we generally think about it. So somatization is the tendency for psychological stress to manifest in the form of physical symptoms. Hypochondriasis, we're all familiar with. This is essentially the persistent preoccupation with the possibility of having a serious and progressive physical disorder. And there's really 2 beliefs that you can think about here when it comes to like a neuropathic pain. The simplest model is that all symptom reports involve perceptions that accurately represent reality. The other one is that patients can be malingers or hypochondriacs. And in this case, there's so many symptoms, it's impossible to believe that they all represent reality. But for the first time now, we can actually see objective evidence of corneal nerve abnormalities in patients with unexplained ocular pain. So this is a patient of mine that looks like she was treated like a dry eye patient for 30 years. She couldn't keep her eyes open. Her eyes were squeezed shut all the time due to intense eye pain. But there's no dry eye present. There's nothing that looked like dry eye. We imaged her corneal nerves and we see these microneuromas here. We see it's all these little balls there. We see tortuosity, nerve beating. We see nerve sprouting of those nerves. And I prescribed her Lyrica, so pregabalin, an oral medication for nerve pain. And her pain was 100% better within 2 weeks. So that would not have resolved with typical dry eye treatments. So we have to rethink our dry eye. So neurosensory abnormalities have been recognized as contributors to dry eye since 2017, but we don't often think about it. We have to accept that there's many forms of pain whose cause is unknown, and we have to start thinking about neuropathies and mental health conditions as contributing or causative factors for our patients. So some people say, well, how in the world do all these corneal nerve disorders actually arise? And I like to say, well, how do they not arise? Look at these risk factors our patients have. Dry climates, pollution, UV light, surgery. This is a huge one. We're severing 270 degrees of the corneal nerves whenever we do LASIK. And we're hoping and praying that it is going to grow back normal. And most of the time, the corneal nerves will grow back at a rate of 1 millimeter per month or so. Most of the time, those patients end up being totally fine. Their corneas heal. They're not in debilitating pain. But maybe it's about 0.1% of the time, patients are in so much pain after LASIK that they become suicidal. And those are cases that we've damaged the nerves and they didn't grow back properly. And it damages that subbasal nerve plexus. There's systemic medications that affect the nervous system. There's topical medications like glaucoma drops that impact the eyes and can actually be toxic to the nerves. And there's chronic medical conditions that affect the nervous system as well, and chronic ocular conditions that affect the nervous system. So there's lots and lots of risk factors that our patients actually have for nerve damage that I think we kind of just gloss over, and we think like, oh, they don't have any risk factors for a nerve problem, but a lot of patients actually do. So the first one that we're going to talk about is neurotrophic keratitis. So in this case, their pain status is good. They're generally not feeling a lot of discomfort, but their ocular surface status is poor. So there's desiccation of the cornea, there's non-resolving punctate staining of the cornea, but in general, their symptoms are not too bad. Those are going to be the neurotrophic keratitis cases. Estimated prevalence, 16 out of 100,000. That's extremely outdated, and we now know that it's far more prevalent than that. The only FDA-approved drug to treat neurotrophic keratitis pretty much every single year is written 60,000 times, even though estimations from 10 years ago say that only 65,000 Americans have neurotrophic keratitis. So we know it's much more prevalent than we thought. It can stem from the corneal nerves, the ocular nerves, trigeminal nerves, central nervous systems, systemic disease, genetic conditions. But by far, the top causes of neurotrophic keratitis are herpetic infection, simplex or zoster, intracerebral tumors or surgery, topical medicamentosa, which is usually through glaucoma drops and the preservatives associated with glaucoma drops, chronic ocular surface disease, or diabetes. In our clinic, we see all of these. We're attached to a hospital, so I have lots of patients that come in after a brain surgery that now have stage 2 or stage 3 neurotrophic keratitis. One study estimated that 18% of type 2 diabetics have reduced corneal nerve sensation, so actually have a neurotrophic cornea that could become a neurotrophic keratitis in the future. When we think about the stages of NK, stage 1 is punctate keratitis, stage 2 is when you get an epithelial defect, and stage 3 is when that defect actually starts to thin. Now, differentiating stage 1 versus dry eye is difficult. So this is probably one of the most common questions I get asked. How do you know if it's stage 1 neurotrophic keratitis or dry eye? The problem is that the symptoms are very similar, generally some mild symptoms, irritation, foreign body sensation, light sensitivity, and the signs are similar too. You just see some fine punctate staining. Stage 1 NK is also always associated with dry eye, because if your nerves aren't working well, your blink rate goes down and your tear secretions go down. So if you have stage 1 neurotrophic keratitis, you will also have dry eye. So what differentiates stage 1 NK from dry eye is that as neurotrophic keratitis worsens, the discomfort is actually going to improve. So as it gets worse and those nerves aren't working very well, all of a sudden patients' eyes are actually more comfortable, but their cornea is becoming more desiccated. So the vision gets more blurry, but the comfort actually improves because those nerves aren't actually telling the brain how much pain the eye should be in. This is opposite of dry eye, where generally as it gets worse, your symptoms get worse. So with stage 2 and stage 3 neurotrophic keratitis, there's less discomfort and you have increased symptoms of blurry vision. But the hallmark of neurotrophic keratitis, and the best way to differentiate neurotrophic keratitis from typical dry eye, is the reduction of corneal nerve sensation. So when should we be thinking about checking corneal nerve sensation or how well those nociceptors are working? When traditional dry eye therapies have failed, if signs are much more present than symptoms, so a lot of corneal desiccation, but not a lot of discomfort, if the cornea has any irregular epithelium or any edema to it, and if the patient has any risk factors for NK, that's when we need to check sensation. Fancy term for this is esthesiometry. This is assessing a patient's reaction to a brief corneal stimulation to give you functional insight into the status of the nerve. So you're testing those mechanonociceptors and you're testing those polymodal nociceptors, seeing if the response is absent, reduced, normal, or increased. If it's absent or reduced, then that is diagnostic for neurotrophic keratitis. If it's increased sensitivity, it could indicate neuropathic pain. I'm going to skip this slide. This is generally how we test things in our clinic quantitatively, but how most people are going to detect neurotrophic keratitis is qualitatively. Something like a cotton swab, dental floss, tissue paper, because it's low cost, takes little time, little training, readily available. But it is difficult in bilateral cases because you don't have a control eye to compare it to. So how do you test this? You are going to start with the unaffected eye, if there is an unaffected eye. You're going to ask the patient to look straight ahead, fixate somewhere on the wall, you're going to approach the patient laterally so they don't actually see you coming up to them. And you're going to tell the patient that you want them to let you know whenever they feel something touching their eye, not whenever they see it. Then you need to check the central, superior, inferior, nasal, temporal, all the different quadrants. If you think about cataract surgery, you're making incisions in 2 different spots of the cornea. You can get a sectoral NK that's only affecting those certain spots. So we want to check everywhere. Then you can judge it like this. Is the response absent, reduced, normal, or increased? Or you can grade it on a numerical system like 0 to 3, 0 absent, 3 hyper. So some helpful hints here. If it's absent, they absolutely are not feeling anything at all. You're sitting there poking them, they don't feel it. If it's reduced, they're going to probably barely feel it, and it may not elicit a blink reflex. If it's normal, when something touches the eye, they're going to probably pull back a little bit and blink. If it's hyper, that's probably the case where you touch the eye a little bit, the patient throws themselves on the ground, and they say that they're in tons of pain and threaten to sue you. So just kidding. But there are, some cases that are a little bit more dramatic like that. So how do we document this? So this is an example of, this is not pictures from my clinic, but kind of an example case. I mean, I've had many patients that have had a stage 2 neurotrophic keratitis right after a herpes zoster incident, and they've gotten a uveitis with it, but then all of a sudden they develop stage 2 NK very quickly afterwards, and they were referred from our uveitis clinic down to our dry eye clinic. So you test the unaffected eye first. That's the left eye. It was normal. You test the right eye, the affected eye. You find that has reduced sensation, and you would call that a neurotrophic keratitis. So the original school of thought by Mackey was that you pretty much just use supportive therapy until you reach stage 2 or stage 3. Things like artificial tears, punctal plugs, warm compresses, maybe some dry eye drops. But generally, it was said to not do restorative therapy until it's stage 2 or stage 3. I very much disagree with this. I've seen a lot of stage 1 progress to stage 2 and stage 3. You don't want to be the practitioner that is sitting on a stage 1 neurotrophic keratitis and have it turn into a stage 2 where the patient is at serious risk of getting an infection or losing vision. So I treat all of my neurotrophic keratitis patients with a restorative therapy, things like amniotic membranes, autologous serum eye drops, platelet-rich plasma, or recombinant nerve growth factor. Could also use insulin eye drops too. So this brings us to poll question number 3. What is the most reliable method to differentiate stage 1 neurotrophic keratitis from quote unquote dry eye?
Any questions, Joe, while that polling question is going through?
One came in a while ago. Is Pizio similar to piezoreceptors? I'm not sure I followed the question.
Oh, the Pizio ion channels?
Yeah.
I think in other areas of the body, sometimes it's referred to as there's Pizio receptors. Too. In the eye, we're just calling them mechanonociceptors, but it's my understanding that a Pizio receptor is similar to the mechanonociceptor functioning through that Pizio ion channel.
Very good. We're caught up.
Go back one slide. I always like pointing this out when I do my cornea lectures. Or maybe it's that's it right there. Like everyone to look as they're answering this question is that look at stage 2 and you have that wound, but if you look at the edge of that wound, you're starting to see that sodium fluorescein be pulled into the stroma. And what I always like to ask the audience is what's the flow of fluid through the cornea, front to back or back to front? And where I'm going with it is when you have intact sodium, when you have an intact epithelium, if I put sodium fluorescein in and Joe calls me and I come back in 10 minutes, the sodium fluorescein is still in the tears. But if there's a, abrasion on the eye, put sodium fluorescein in, hey, Kaleb calls me, he rarely calls me, let me take this call. I walk out of the room, I'm on the call for him with 10 minutes, I come back, the endothelial cells are pulling stuff into the cornea. And you could see it there on that stage 2 picture. If you look at that little haze, that epithelium is being pulled in there. That's the importance of this. And that's why, Kaleb is saying that's an increased risk of infection because, when that epithelium is broken down, the endothelial cells are sucking things in. That's why, like after a herpes simplex, you usually get a sterile ulcer because the endothelial cells take that dead protein and pull it into the stroma, and if there's a lot of it, into the anterior chamber, and you get that immune reaction. So the epithelium is super important here. So, and that's why there's that increased risk. All right.
That's a great point.
So here we are. We've got 15% going with A. We got 7% going with B, and 70% going with cornea sensation testing, and then 7% going with D.
Yeah, so there's no wrong answer here in terms of, what could help you differentiate. The question is, which one is best? And what the only thing that definitively says that it's NK versus dry eye is corneal sensation testing. But all the other ones, A, B, and D, can clue you into when you should do corneal sensation testing. But it's not really confirmed until you know that you have decreased corneal sensation. All right, so we're going to shift gears to neuropathic ocular pain here. So when we talk about neuropathic ocular pain, we're talking about this quadrant here. So the pain status is bad, but in general, the ocular surface status is good. So your patient could be anywhere here. Now, I included one right over here in the dry eye section because it is important for us to realize that these are not true quadrants in the sense that there is zero overlap. You can absolutely get an overlap between dry eye and neuropathic pain. What would clue you into that is that there's just way more symptoms than there are signs. But you can still have dry eye, but still have overstimulation of the nerves and oversensitization of the nerves. So there's overlap sometimes between dry eye and neuropathic pain. There's also overlap between neuropathic and neurotrophic keratitis. There can also be overlap between dry eye and neurotrophic. So it's not perfectly organized into these quadrants here. Very important to realize.
I was geeking out with one of the MSLs, and I just want to run this past you, is that we were talking about before an eye goes, so you have normal, say, sensitivity to the nerve, and then neurotrophic, obviously they don't have any sensation, but we were geeking out and talking about how before they go neurotrophic, they actually go hypersensitive for a period and then kind of crash and kind of desensitize. Is that what your science has shown you or what your background has shown you?
I don't know if it always has to go in that trajectory. I don't know if it always has to go hyper and then hypo. I think that there's many different ways that it can go. Like, for instance, you can have, chronic dry eye where there's, you're experiencing dry eye, but the damage is persisting there for such a long time that your sensation just goes down and down and down. But you can get the confusing part there is when you get neuropathic and neurotrophic at the same time, where those fibers can convert at any point from A fibers sensing touch to C fibers conveying pain. And to me, that does not have to happen at a specific time. That could happen at any point in the disease.
Perfect.
So neuropathic is the classically thought about as pain with no stain. I don't exactly like that description because there can be stain. This throws off a ton of people. But the classic example is pain with no stain, where you have patients that come in, eye pain, eye ache, light sensitivity, intense burning, pain radiating from the eye. Then you look at the eye and it looks perfectly normal. To understand neuropathic pain, you have to understand the terminology associated with it, because this is very foreign to optometry and ophthalmology, but classically known to things like anesthesiology and neurology. The first is allodynia. This is evoked pain from an innocuous stimulus. So in layman's terms, this is something causing pain that should not cause pain. Examples of this is photoallodynia. So like if you're staring at the computer right now, which is emitting kind of just normal light, a lot of blue light, and you're kind of doing this and it's killing your eyes, causing horrible pain, that is photoallodynia. So you could call that photophobia, but I call it photoallodynia because it's a light source that should not be causing pain that is causing pain. So you can change it from phobia to allodynia. You can have cold allodynia. This is like patients with dry eye that go outside into cold weather and their eyes immediately start to kill them. Just horrible, horrible pain. That is cold causing pain that shouldn't cause pain. There's tactile allodynia. I've had patients come into my office that say if they lightly touch their upper lid, it will cause excruciating pain for the rest of the day. They're not talking about the eye. They're talking about the eyelid. So you can get pain of the eye, but if you think about the course of the trigeminal nerve, you have the supraorbital and infraorbital nerve, and then it courses over here too. So these patients can sometimes, they'll literally come into your office and say, I have eye pain. They'll say it radiates. You say, where's it radiate? And they'll be like, it's here, here, and along here. And they'll literally point along the different, pathways of the trigeminal nerve. So it could be right along the temple and the top of the eye as well. So we're talking about something like light kills my eyes with allodynia, where the stimulus intensity is very low, and you would expect the pain to be low. But with these patients, it's a low stimulus, but a high amount of pain. The second term that we have to be familiar with to understand this is hyperalgesia. This is increased response to a stimulus. So think about wind. So wind should bother your eyes. It does not feel pleasant on the eyes whenever there's wind, but it shouldn't cause horrible pain either. These patients will say, I'm so sensitive to wind. So you've got a stimulus intensity that's maybe moderate. It should cause a moderate amount of discomfort, but it'll cause extreme discomfort in these patients. So allodynia, pain that's happening whenever there should not be pain, hyperalgesia, increased pain in response to a stimulus. There's also the concept of windup. This is repeated exposure to a stimulus over time increases pain. So this could be like you go out inside, a cold, windy day and your eyes bother you a little bit. Then you're out there a little more, and all of a sudden your eyes become more and more painful the longer you're out there. You can get this concept of windup. There's also prolonged pain. So this is kind of like when my patient told me that they lightly touch their eye and they're in pain the rest of the day. If you press on the eye, it causes pain. It doesn't feel good, but that pain should drop off pretty quickly. In these patients, it does not drop off very quickly. It takes a very long time for the pain to go away. So what are risk factors for neuropathic ocular pain? Well, interestingly, there are a lot of the exact same risk factors for dry eye, which kind of clues us into what's going on with the nervous system. This was a brilliant study that was done by Anat Galor out of Baskin-Palmer. She took two separate groups of veterans. One group that you see here had chronic pain syndromes. So things like, fibromyalgia, small fiber neuropathy, migraines, trigeminal neuralgia. Then this group here had no chronic pain syndromes. Both groups had equal dry eye signs. So equal dry eye signs, chronic pain syndromes over here, no chronic pain syndromes here. The side that had chronic pain syndromes had worse dry eye symptoms and higher evoked pain than the group that did not have any chronic pain syndromes, which pretty much showed that in this case, these patients were experiencing their symptoms not from dry eye, but related to the chronic pain syndrome. So in that paper, she said, although these different disorders manifest in different parts of the body, they're found to coexist and are likely tied together by a unifying pathophysiology linked to neuropathic mechanisms. The way I tell patients is that pain travels together. You have back pain, you have muscle pain, you're more likely to get eye pain. The way I like to think about it and tell providers is this: dry eye symptoms can actually be a peripheral manifestation of a systemic disease. So what is actually happening here? We'll go over a few different examples of things that can happen, but honestly, there's kind of an infinite number of examples of what could happen. So let's say you take a bunch of inflammatory soup, just a ton of different pro-inflammatory molecules. Let's say you drop it directly onto the ion channel of one of those nociceptors. That pro-inflammatory environment can actually sensitize those ion channels and then the nervous system themselves. And the ongoing nociception leads to that central sensitization. And then all of a sudden you get this maladaptive neuronal plasticity, and the nerve continues to fire and continues to fire even when you take away those inflammatory mediators. So you can get spontaneous firing of nerves, higher excitatory neurotransmitter release, enhanced conduction, increased response. You can get nerve sprouting, nerve rewiring, and then kind of what we talked about, conversion of non-nociceptive fibers into fibers that are exhibiting a nociceptive phenotype. So this patient that you see up in the right, that was a patient of mine that was very myopic, and he had an uncomplicated PRK procedure. He wound up 2015 after the procedure. Everything looked great, except he was in debilitating pain. He sold a company in his mid-20s for $40 million. So he was very wealthy, had private jets. He was a pilot. He flew all over the entire country trying to find someone to help with his eye pain. Everyone said, your eyes look fine. Like there's no dry eye at all. We don't know why you have dry eye pain. He came to see us. We imaged his nerves. That's what his nerves look like. They look terrible. And you don't see any of those A fibers there, those straight, thick ones. All you see is C fibers, those tortuous ones that are associated with pain. So he had conversion of the A fibers to the C fibers. We put him on high concentration serum drops and a low corticosteroid. And he did that for a year. And his pain went from 10 out of 10 suicidal to like a 1 or 2 out of 10. He's doing amazing now. Actually doing a little bit better now on a PRP because we finally got him some PRP, which is working great. But if you treat that like dry eye, it's not going to go over very well. He had tried every single dry eye medication that existed.
So hold
in
on
mice,
1 second. So hold on,
Yeah.
because we always get comments in the survey about when we start using acronyms. So let's just take a step back. When you said serum tears, are you talking like autologous serum tears?
Yes, and we'll go over the treatments of peripheral neuropathic pain in a moment. But yes, when we say serum tears, autologous serum eye drops, so eye drops from your own body, you get a blood draw, spin it out, take out red blood cells, leave, well, in platelets, you take out those factors, leave in the rest, and then you're dosing it usually at least 4 times a day in the affected eye.
And
then
then PRP is not pan-retinal photocoagulation. So go ahead with the PRP.
No, PRP, although PRP pan-retinal photocoagulation can cause neurotrophic keratitis. I've actually seen a rare case of that, lasered the ciliary nerve. But
Right.
anyway, PRP is platelet-rich plasma. It's like autologous serum eye drops, but you leave the platelets in there. When you do that, you get about 14 to 20 times the nerve growth factor. So it can help the nerves quite a bit more. So you're essentially providing the support to the nerves that the epithelial cells are supposed to be providing, but they're not working well to provide that support. Then there's other things like platelet-rich and growth factors and all these other acronyms. There's tons of variation spinning off from it. That essentially they're just kind of altering platelets and changing the amounts of growth factors present. So in this study, they took mice, they removed the lacrimal glands from the mice, and they looked at those cold thermoreceptors. The cold thermoreceptors are trying to detect surface wetness. And when you took out the lacrimal gland, it led to the cold thermoreceptor becoming sensitized. So there is a decreased evaporation threshold. So instead of it taking maybe a 2-degree temperature shift for the cold thermoreceptor to fire, it was now firing in maybe a 0.5 degree temperature shift of the cornea. So it increased firing frequency and ended up leading to symptoms in those patients, or in those mice, I guess, not patients. So when we talk about central sensitization, so we have these ascending pathways that convey pain that are actually modulated. So ascending pathways are modulated by these descending pathways. So these descending pathways are inhibiting the ascending pathways, but you can lose the inhibitory effect of the descending pathways. So now the descending pathways can no longer inhibit the ascending pathways conveying pain. When that happens, you can very quickly spiral into a chronic pain state. So it creates a negative feedback loop. It's increasing pain perception. It's causing a chronic pain state. They're getting disproportionate amounts of pain, and their pain is staying even after the stimulus is gone. And that's more of an example of like a central sensitization. So when we image the corneal nerves and we're trying to see what's actually going on with like corneal neuropathic pain, we're looking for decreased nerve density. So this photo on the right is abnormal. There's not enough nerves there because your nerves will actually prune themselves back a little bit in cases like this. So you get decreased nerve density, you get microneuromas and hyperreflective foci, which is what you're seeing pictured here. Then you can also start to get nerve beating, nerve sprouting, and nerve tortuosity. That's an example of a very unhealthy subbasal nerve plexus of the cornea. So there's many different types of neuropathic pain, and this makes it, kind of confusing. You're trying to figure out what's causing it, what is it associated with. So there's post-surgical, after a LASIK surgery perhaps, there's migraine associated neuropathic pain. This could be associated with like trigeminal neuralgia too. So you get bad migraines, you also get associated eye pain with that. You can have, traumatic type neuropathic pain. So that can start after maybe a TBI or chemotherapy. And then there's atypical ones too, which cross over somewhat with migraines. Like if it's, a trigeminal neuralgia, but sometimes, if you're talking to neurology or pain specialists, they'll just call it like an atypical neuropathic pain. They don't really have a good explanation for it. So there's an optometrist at Harvard that's working with Baskin Palmer and doing a whole lot of studies with functional MRIs and trying to see, what's actually going on with the pain perceptions in the brain. And they're studying kind of that nociplastic pain, which is essentially just a disorder of the pain processing centers of the brain. And we don't know a lot about it, but there's more and more research coming out with that now. So this is going to be a poll question specifically about neuropathic pain and terms associated with neuropathic pain. So which term describes the occurrence of pain in response to a stimulus that would not typically cause pain? Is it allodynia, hyperalgesia, prolonged pain, or wind up?
The polling question is open. And Joe, are there any questions that have
Yeah,
rolled in?
Caleb, there's a couple of things that came in. One is a few minutes ago. How long does your dry eye testing take? Most people have only 15 and 20 minutes to analyze and diagnose. Quick tests used are usually T-butt or Schirmer strips. What do you use, and how long does it take?
Yeah, my dry eye workups, I have 30 minutes allotted for patients. I have friends that work at universities that have 2 hours for a new dry eye patient. I don't do corneal sensation testing on every dry eye patient that comes in, only if I feel like they really need it. And generally, once you've done it enough, you can kind of tell when they need that testing. So we're doing meibography, tear osmolarity, MMP9 testing for inflammation. I do Schirmer's testing on all my patients, not me, but the tech does. And then I'm really looking at tear breakup time. I'm looking at tear meniscus height. I'm looking at the number of meibomian glands yielding a liquid secretion out of those central 15. So I count 15 glands. I press on the lower lid and I see how many of those are secreting. Is it 7 out of 15? Is it 1 out of 15? And then I'm grading the quality of the secretions. If it's clear, cloudy, moderately turbid, or inspissated. Then I'm doing, careful examination of, the eyelids, eyelashes, looking underneath the superior lid, things like that, trying to make sure that the tears are draining, through the puncta. So, I mean, my dry eye workups, the tech is probably with the patient 20 or 25 minutes. I'm generally with the patient probably about 20, 30 minutes or so.
Yeah, I think the challenge comes when people are taking your information and trying to assimilate how they would do that in a primary care practice. But we have to recognize yours is a specialty care practice that focuses on this. You may not be doing swollen optic nerves or double vision patients or post-operative patients. Yours is very special. So I think people are just trying to see what is that way to assimilate what you do into a general practice. So I think that was a question about the time.
A lot of what we do, we're just gathering data for research. Like you don't need tear film osmolarity that much. You don't necessarily need matrix metalloproteinase 9 testing that much. It's helpful, but not necessary to treat all this. When we're in this clinic, so we also have confocal microscopy. There's only like 20 of those in the country. Ours actually just broke, so we haven't been able to use that lately. So I can tell you don't actually need it. But I mean, it's kind of a luxury that we have. But really, we're trying to decide when it makes sense that it's neurotrophic, when it makes sense that it's neuropathic, when it makes sense that it's just straightforward dry eye. You don't actually need all the fancy tests to do that. You have to have a very good understanding of the symptoms that your patients are experiencing, what you're seeing on the ocular surface, and then checking corneal sensitivity if needed. But you really don't need a specialized clinic to do a lot of this. We just happen to do a lot of other stuff because we have it and we do research with it.
I think the
And
biggest
you,
highlight that I would say is one, you can always bring the patient back. The patient might come in and they
Yeah.
could say, hey, look, this is getting more complicated. Let me try this and let's kind of see where you end up. But I think, the best part of what, Caleb's covering tonight too is if it's the dry eye patient, where probably, let's say the majority, and maybe I'll shift that a little bit, but we thought the majority were. But then the key is making sure that we differentiate those neurotrophic and neuropathic. Those are the ones that can really cause us to chase our tail by doing all that other testing that we're used to doing. But we have to figure out that when it's neurotrophic versus neuropathic, that the treatments could be different.
Hmm.
and
Definitely.
Caleb, you're using confocal microscopy to image your nerves, correct?
Yes. But again, you really don't need that. Like our machine is down right now,
Mm-hmm.
not working, and I can still
Mm-hmm.
diagnose neuropathic corneal pain without it. It's just nice to have, and it helped prove to me
Mm-hmm.
that I understood the concepts. Like, I wasn't comfortable coming up with a lecture like this until I had definitively seen evidence of neuropathic corneal pain when I hadn't seen any signs of dry eye, and I was trying to wrap my
Mm-hmm.
head around why there had so many symptoms. So it
Now,
it helped teach it to me, but you don't need it to practice.
do you have a sense of how much your confocal microscope costs?
80,000.
How much?
$80,000.
$80,000 and it's down, eh? It's kind of funny. $80,000 doesn't buy what it used to buy anymore, does it?
It does not. And you can't bill for it. There's no code to bill for confocal
Mm-hmm.
microscopy. We actually bill a slit lamp photo for every time we do
Mm-hmm.
it, which is crazy. You get like $3.
So
All
your
right.
polling question came with 69% going with allodynia, and then
Yes.
21% B, 1% going C, and 8% going wind up.
Okay. Yeah, so this one is allodynia, so pain in response to something that should not cause pain. Think about light sensitivity from like indoor lights. I had a patient with trigeminal neuralgia that says when she goes out to eat at restaurants, she has to unscrew the light bulbs at the tables because just those light bulbs induce so much pain. I said, oh, that is classic photoallodynia. Hyperalgesia is exaggerated pain to something that should cause a little bit of pain. So, you can think about wind, wind is affecting the eyes. It should cause a little bit of discomfort, but not excruciating. Or if you're checking corneal sensitivity on someone and you lightly touch their eye and they throw themselves backward, in horrible pain, that would be like hyperalgesia. Um, Prolonged pain, when it takes a long time for the pain to go away. Wind up is repeated exposure to something, causes increasing pain over time. So like, a dumb example is like if I were to like lightly tap my arm over and over and over again, someone that had like a neuropathic pain affecting the peripheral nervous system of their arm, like eventually that could really, really hurt them, cause extreme pain. Whereas it shouldn't really end up doing that.
I think probably the most common allodynia that's out there that our audience would probably be aware of, maybe pointing it out, is that how many times have we had patients say, when I go into Walmart, those lights kill my eyes, or
For sure.
or the
Oh yeah.
Target. And to me, it's kind of the cheap fluorescent blue light, and you probably have more of a scientific reasoning for that. But it's always that Walmart or that kind of Target light. So I'll let you kind of go down that
Yes.
road.
Yeah, I think that the spectrum with blue light seems to be more of a problem. Lesser with incandescent light bulbs, more with fluorescent light bulbs, and some of it is probably through the IPRGC pathways. It's the blue light stimulates those specific photosensitive retinal ganglion cells, and that has been shown to project to pain areas of the brain and areas associated with photophobia. So it probably has something to do with that. But yeah, that's a really good example because you should never have a patient coming in that like says that absolutely kills their eyes, that they can't walk into a Walmart, so that they have to like stay in their basement all day because any overhead lights hurt, and you shouldn't have the patients that are having to wear 3 pairs of sunglasses when they come into your office, or they're in a dark room still with sunglasses on. That is a very classic example of a photoallodynia. So what should we do if we suspect a neuropathic ocular pain? So the first thing is we need to be trying to clue ourselves in if there's allodynia or hyperalgesia, pain when there shouldn't be pain, or exaggerated pain. We need to look at when and recognize that these patients should have way more symptoms than they have signs, but recognize that there can be coexisting ocular surface disease. You could ask them something like, do your symptoms improve when you close your eyes? When you close your eyes really should feel better if it's dry eye, unless you just squeeze your eyes really hard. But if you lightly close your eyes should feel better. Then we have to figure out if the patients have any risk factors. There's only been one case of neuropathic pain that I absolutely could not find a single risk factor for, and I was just completely thrown off. Almost always, you can find some other risk factor that they have or some other chronic pain syndrome. We can use proparacaine to disrupt corneal nerve input. This is extremely helpful here. So we'll go over this quickly, but we do this in our clinic all the time. So not with our typical dry eye testing, but when the circumstances arise, we do more dry eye testing. So you want to take your patient's baseline amount of pain, call it burning or grittiness or discomfort, sometimes itchiness. Strangely enough, itchiness is very correlated with neuropathic pain, and then light sensitivity. You want to instill proparacaine into both eyes. You don't tell them what the drop is, you just put it in. You wait 60 to 90 seconds, then you assess their new amount of pain in photoallodynia. Photoallodynia may not always be present, so it's whatever symptoms that they have. If the pain has gone down, then that means that we've numbed the corneal nerves. If you numb the corneal nerves, it should improve pain. So the pain has gone down. It's either nociceptive pain, which is dry eye. So it's either dry eye, or it is a peripheral neuropathic pain. So you have to try to figure out, their eyes got better when I put a numbing drop in the eyes. So is the dry eye causing it, or is it the peripheral nervous system, like the corneal nerves? And it's your job as the person wearing the doctor's hat to figure out which one it is. If their pain remains the same after you put a numbing drop in the eye, that should clue you into there's something kind of weird here, because if I put a numbing drop in the eye and it doesn't improve their eye pain, where is this pain coming from? It can't be from the corneal nerves because you just numbed the corneal nerves. So in this case, it is a central neuropathic pain, or it's non-ocular in nature. It could be binocular vision. I've had some cases like that. So we use proparacaine to isolate where the pain is coming from if we have a patient that we suspect that it's a neuropathic pain. And I've had many, many times that I've been treating someone for dry eye, or I've been treating someone for what I think is maybe a peripheral neuropathic pain. I'm just like, this isn't working at all. And then I go and I put a numbing drop in the patient's eye, and they say their symptoms are the same. And I realize, oh, well, that explains why my treatments aren't working, because I'm not going to be able to successfully treat their symptoms with drops if a numbing drop isn't even able to treat their symptoms. So can you have peripheral and central neuropathic pain at the same time? Yes, it's actually super common to have both. So in this case, maybe you put a numbing drop inside the eye. The patient says they have 60% reduction in pain, maybe 70% reduction in light sensitivity. That would tell you that most of the pain is coming peripherally because the numbing drop helped quite a bit. So 60 to 70% of it is probably a peripheral neuropathic. 30 to 40% is probably central neuropathic. Remember, if you have peripheral neuropathic pain long enough, it can turn into a central neuropathic pain. So, if it's a case like this, it's still worth it to do topical treatments because the majority of the pain is coming from the periphery. If it was the inverse, you'd have to decide. It may not be worth it to do topical treatments at that point. This is one that honestly probably no one is going to do. I don't even do this in clinic, but some people do. Pedram Hamra at Tufts is probably the biggest advocate for this. It's a hypertonic saline solution. So you essentially do the same thing based on amount of pain, light sensitivity. You install Muro 128 into the eye. Then you assess their new amount of pain and light sensitivity. When you stick Muro 128 in the eye, it should cause like a little bit of an increase in pain. Like it should burn some, like it should be uncomfortable a couple minutes later. Not horrible, but should cause some discomfort. Then it's more traditional dry eye or like a peripheral neuropathic pain. Or more just a traditional dry eye. If it increases a little bit. See, I don't even do this test, so I have to look at the chart. If they have a huge increase in symptoms, so a few minutes later, still that Muro 128 drop is causing tons and tons of pain, that is kind of evidence of the prolonged pain. which is evidence of like a neuropathic corneal pain. So if they have a normal response to Mira 128, traditional dry eye, a lot of pain with Mira 128, it could be indicative of neuropathic corneal pain. I've never done this test in clinic, but it is something that some eye pain clinics will do. So what about treating neuropathic ocular pain? First, you have to decide, is there associated ocular surface disease? If there is, you have to treat it first. You will never get neuropathic pain ever under control if you don't treat any dry eye that's present first. Dry eye, again, nociceptive eye pain first. The reason for this is if you're still getting an input of nociceptive signals, so you're still getting, dry eye signals that are passing through those corneal nerves, then it's going to continue to cause that patient pain. So you have to get the dry eye under control first. If the pain persists after the dry eye treatment and you get that under control, then you have to start thinking about neuropathic corneal pain or a central neuropathic pain. You need to figure out what symptoms they have, what is aggravating it, wind or light, when did it start? What's their time course for? Does it happen with migraines? Did it happen after they had a LASIK surgery or, underwent chemotherapy or had traumatic brain injury? Is it one eye or both eyes? If it's trigeminal neuralgia, it's usually just one eye. So you're only focusing on one eye. You need to figure out if they have any risk factors for neuropathic pain. Use proparacaine testing to detect if it's central or peripheral. And then we have to set expectations for these patients because there definitely is no cure for neuropathic ocular pain. If it is a peripheral neuropathic pain, so think about the cases that the numbing drop actually did help relieve the majority of their pain. We treat the dry eye first, definitely. Then there's plenty of evidence that you can remodel that subbasal nerve plexus of the cornea using a combination of high concentration serum drops, let's say like 50% concentration autologous serum eye drops made from your own blood, and a topical immunomodulator, a cyclosporin or a Xiidra, or lifitegrast, or a low-dose corticosteroid. So I'm usually doing high concentration serum, and I'm trying to do either lifitegrast or a high concentration of cyclosporin. In some cases, I'll do a high concentration serum and like a load of prednol or a fluoromethalone once or twice a day for an entire year. Obviously, you have to be checking and making sure they don't have an IOP spike. Ideally, they're pseudophakic. You educate them on risk, you check them for infections, things like that. But, sometimes these patients are in so much pain. You tell them like you could, develop premature cataracts, and they say it's worth it if I can get rid of this pain. So you have to do something like that, and you have to give it time too. The subbasal nerve plexus does not remodel overnight. The epithelial tissue generally regenerates in like a week. The nerves are regenerating over the course of months and months and months. So I tell patients, expect to be on this treatment for a year. Don't expect any improvement in symptoms for 6 months or so. Like, it's going to take time. So that's kind of my go-to: high concentration serum and either a topical immunomodulator or low-dose corticosteroid. You can do punctal plugs.
So help me out with that before you move on. You said a
Mhm.
high dose cyclosporin. I know that, Restasis is like whatever 0.05%, and then or
Yeah.
0.5%. Then we had Sun come out with 0.9, and I think Vive is 1%. Are you getting this mixed, or are you using one of those concentrations like at a 1% or 0.9?
No, I'll try to do the 0.09 or the 0.1% for cases like that. I just try to not do the lowest, which is the 0.05. I think that the lowest doesn't work that well, so I just try to do something that's a little bit stronger. Sometimes I'll compound through a pharmacy in New Jersey a 0.1% cyclosporin that works pretty well and is pretty affordable if their insurance isn't covering it well.
And then the other thing that I have done in the past, because it's been, said, use it twice a day to be on label, blah, blah, blah. I usually just tell them to use it, 4 to 6 times a day. Is that anything that you would agree with or make comments on?
Yeah, I've never seen a problem with using, some of these drops 3-4 times a day. It's even 0.05% cyclosporin has been studied 4 times a day. and still wasn't even detected in the bloodstream and didn't have any adverse effects on the eyes. So I think it's safe to play around with the dosing of topical immunomodulators a bit.
Okay, perfect.
Hey,
You can do
Caleb, a question
Oh, yeah.
just rolled in. Would albumin eye drops work similar to PRP or serum?
I haven't used albumin eye drops before. I've read a little bit about it. I've been intrigued by it, but I don't really have any experience with it. To me, what you're trying to get, though, is the nerve growth factor. Like, you really are trying to get the nerve growth factor from the blood. And I don't think albumin would do that. So the reason you're doing high concentration, basic fact that there's more nerve growth factor. Platelet-rich plasma works well because there's more nerve growth factor than there is in serum tears. So my thoughts is that, maybe it could help, but I wouldn't use it instead of PRP or serum eye drops. So you can use punctal plugs, but punctal plugs could be a double-edged sword. There is inflammation associated with neuropathic corneal pain. And if you don't get the inflammation under control, you're now holding inflammation on the eye. You could make things worse. So you have to be very careful with plugs and peripheral neuropathic pain. Make sure that inflammation is under control first. IPL can be quite helpful, mostly because you're reducing inflammation. Scleral lenses are not therapeutic in this case. They're just literally reducing the nociceptive input to zero, which can be very helpful. You don't want the nociceptors firing at all, from dry eye or anything else. So you put a scleral lens on there, you're reducing that input to zero. So you're eliminating the dry eye component of the pain, or the nociceptive component of the pain. FO41 tinted glasses work great for light sensitivity. That's not present in all peripheral neuropathic pain, usually just associated with migrainous or trigeminal neuralgia. Alpha lipoic acid is a supplement that is used by neurologists quite a bit and anesthesiologists for neuropathic pain that, maybe it could help out somewhat with, peripheral neuropathic pain, but, it's hard to say. TRPM8 stimulating compounds, like a drug that may come out later on this year, there's reason to believe that this could actually be helpful for neuropathic corneal pain. It's providing a cooling sensation of the cornea. It's distracting the cornea from pain, and it's increasing your basal tear secretions, which contain nerve growth factor. So there is reason to believe that TRPM8 stimulating compounds could be helpful for this condition. And, there are some over-the-counter drops that contain menthol that you can use. You have to be a little careful. If you get too high of a concentration of menthol, you can overshoot it. You can actually cause kind of more problems. So if you are going to do that, it needs to be kind of a low concentration menthol, and all those drops generally have preservatives in them. So hopefully later on this year, we can experiment with TRPM8, for peripheral neuropathic pain.
And I was at the academy, I think that was Alcon was talking about that. Is that the Alcon medication?
Correct, yes.
Okay,
a Coltremon.
All right, perfect.
FDA approval in May, potentially commercial launch in maybe late summer, mid-late summer. For central neuropathic pain, this is when it gets tricky. This is if you are to go to put a numbing drop on the eye and it does not improve their pain at all. So first off, you should definitely do that if you suspect there's neuropathic pain. You really don't want to waste you or your patient's time or their money prescribing all of these dry eye treatments if even a numbing drop isn't going to help them out. So these are, it's very good and prudent to use a numbing drop and to demonstrate whether or not your dry treatment or ocular surface disease treatment is going to help. So these are the patients that the numbing drop does not help much. I prescribe a lot of pregabalin and gabapentin. I'll prescribe low-dose naltrexone for these patients and have gotten a fair amount of wins. I do not prescribe duloxetine nor triptyline or topiramate for them, but other people do. You can do nerve blocks. So like methylprednisolone or bupivacaine. I work with a pain specialist, and if I suspect that it's further upstream along the trigeminal nerve, I'll send the patient to the pain specialist. He'll do a bunch of nerve blocks. I've had patients that have gone from suicidal, not working, staying at home in their basement, to fully functioning nurse practitioners back working in the emergency room, hiking and skiing again, and falling in love, getting married, like after they've started to get nerve blocks, like just made ridiculous difference to them. You can try TENS units, transepidermal neural stimulation. This works best in migrainous cases, so cases that the patient has migraines and then eye pain associated with migraines. Some neurologists will say that migraines are nothing more than a specific type of neuropathic pain. So sometimes they can also be associated with neuropathic ocular pain as well. Botox injections sometimes can be helpful, not usually in my patients, but sometimes can. And FL41 tinted glasses if there's light sensitivity. We also have to acknowledge the emotional component of pain. This is something that, as eye doctors, we do not like to think about. I really don't like to talk about it. I don't like to think about it, but it's important to acknowledge these same axons that are projecting to brain areas responsible for pain will also travel to brain areas responsible for emotions, which is why a lot of these patients are kind of emotional wrecks on top of being in pain. There's actually like a physiological and anatomical reason for this. So these patients can really benefit from lifestyle modifications, improve sleep, decrease stress, counseling with a psychologist or psychiatrist. Remember, so dry eye patients in general, their symptoms improve with anxiety and depression treatments, despite the fact that that dries out the eyes worse. Because again, it's not just about how dry the eye is, it's about pain perception. And anxiety and depression increases pain perception. So we have to treat that. You can send them out for cognitive behavioral therapy, exercise, massage, acupuncture, things like that can be very, very helpful for patients like that. There's even apps that patients can get. There's one that I really like for patients called Curable. I don't have any financial ties to them, but it's an app that patients use that help them deal with chronic pain. And I've had patients that it's changed their life, to go through the like meditation exercises that they use. So this is the last polling question that we have here. So this is about proparacaine testing. So your patient reports a 20% improvement in symptoms of burning and photophobia following proparacaine testing. What type of pain is most likely affecting this patient?
And you're caught up on questions, so you're good.
Ah, great. Yeah, so in this case, you're suspecting that their symptoms are not coming from dry eye. You're expecting it's coming from the nervous system. You're trying to isolate. Is it the peripheral nervous systems or is it the central nervous system? So you're putting a numbing drop on the eye and they're telling you that they're getting a 20% improvement in their symptoms. And so you're trying to figure out what is most likely triggering their symptoms. Where is 80% of their symptoms coming from?
And, as this question's rolling in, I do a opioid lecture. And one of the points that I like to point out is that neuropathic pain does not respond to kind of your traditional analgesics that are out there, your Tylenols, your NSAIDs, your opioids. So this is kind of overlapping as the question's rolling in, is that, that's why the patient can't take Tylenol and get rid of this pain, or can't take a Lortab and get rid of this pain. Neuropathic pain is a tricky one, and you kind of touched on, like the gabapentins and Lyricas that are out there that do help in some of these cases. So
yeah, I've had a lot of wins with Lyrica and gabapentin and low-dose naltrexone. I mean, sometimes in the right patients, they can really, really help them and be life-changing. And honestly, there's not a lot of risks with prescribing those meds. I mean, you want to be aware of them. You want to start off small doses and increase. There's good ways to do it and bad ways to do it, but I've actually never had a single complication from starting them off on low doses and slowly increasing it. If you're very nervous, which I was a few years ago when I started, you just have to do it at nighttime right before they go to bed, just in case they're going to get dizzy or anything like that. And then, you slowly increase it to twice a day or maybe 3 times a day.
Yeah, pretty, and as we're working with our state boards and expanding our scope, we should be adding these medications on for this reason right here, for these neuropathic kind of
Yes.
pains that we have. So, all right.
It's funny, in our department, a lot of ophthalmologists won't even prescribe that for cases like this, though. Even they feel very uncomfortable with it. So I think it's interesting. Or they just don't want to deal with it, so they send the patients to me. It's probably that.
It's probably, that could be it. I always say that the ophthalmologist, right, their attention span is like 8 minutes, because that's like a cataract surgery. So
That's awesome.
but you're all over the place here. Well, you have 15 or 14% just went down with nociceptive pain, but then we've got 44% with peripheral neuropathic pain, and then 42 with central neuropathic or non-ocular pain. So
yeah, so in this case, the answer would be C, central neuropathic pain or non-ocular. Because remember, you just put a numbing drop in the eye. You just numbed the peripheral nerves. You just numbed the corneal nerves. So the cornea is not firing at this point, and they only got a 20% improvement in symptoms. So if it truly would have been a peripheral neuropathic or pain originating from the cornea, then the numbing drop would have done a lot more. If it is typical dry eye, so nociceptive pain, the pain should have also been gone with a numbing drop as well. So when we're numbing the corneal nerves, we're eliminating the nociceptive input because we're cutting off those pain receptors from firing. We're eliminating the impact of the corneal nerves driving symptoms for patients. So that only leaves a central neuropathic pain. So something further upstream from the corneal nerves that numbing drop did not touch. So it's a weird concept. Once you've seen done a few, it becomes very easy though. All right. So in summary, we need to start thinking about the corneal nerves. So we should start considering a neurotrophic keratitis if there's unresolving corneal staining or defects, if signs are much greater than symptoms, because those nerves aren't working. So there's a lot of signs of corneal desiccation, but they don't feel the symptoms of it because the nerves aren't relaying the information of the damage to the brain. We need to understand if patients have any risk factors: diabetes, herpetic infection, history of eye surgeries, trauma, brain surgery. And then we have to check corneal nerve sensation, because that is what is telling us whether or not they truly have NK. You can try supportive therapies. There's nothing wrong with that. It's not against standard of care to do that. But what's better are healing therapies, things like amniotic membranes, eye drops made from the patient's own blood, so autologous serum, platelet-rich plasma, or recombinant nerve growth factor. Recombinant nerve growth factor is the only FDA-approved treatment for neurotrophic keratitis. 1 drop 6 times a day for 8 weeks, and in general, it works very well.
And I know you're being, because of COPE, but you can say Oxervate. We're not here promoting anyone, but that would be your Oxervate type of medication.
Yes, that is Oxervate. When to consider a neuropathic pain? If symptoms are much greater than signs, so they're in way more discomfort than their ocular surface is telling you they should be in. If they have allodynia, so pain when there shouldn't be pain, or hyperalgesia, exaggerated amounts of pain. Or if they have any risk factors: chronic pain syndromes, fibromyalgia, migraines, small fiber neuropathies, trigeminal neuralgia, history of surgeries, trauma, things like that, you should start thinking about a neuropathic pain. If you have determined that your patient has a neuropathic pain, then you have to understand if it's peripheral or central, and you use the proparacaine testing to do that. If it improves with proparacaine testing, it's peripheral. If it does not improve with proparacaine testing, it's central. Don't waste your time treating central neuropathic pain with eye drops. It's not going to help. If a numbing drop doesn't help with their eye symptoms, your cyclosporine, lifitegrast are also not going to help with their symptoms at all. Your IPL is probably not going to help that much in that case either. You have to be doing something more systemically to help those patients out, or further upstream along the trigeminal nerve. So you have to understand if it's peripheral or central. And lastly, we have to start thinking about dry eye differently. We can't keep thinking about it in terms of, is there dry eye and is there not dry eye? We have to recognize that there's neuropathic pain, there's neurotrophic keratitis. We have to think about the pain status. Is the patient in a lot of pain, like in dry eye neuropathic pain, or discomfort? Does the patient not have a lot of pain, like with no dry eye or neurotrophic keratitis? What is the ocular surface status like? Is it desiccated? Is there a lot of corneal staining? That's more indicative of a dry eye or neurotrophic keratitis. Is the ocular surface pristine and looks fine? That's more indicative of a neuropathic pain or no dry eye. We have to understand that there is overlap. You can't have neuropathic pain and dry eye at the same time. You can have dry eye and neurotrophic keratitis at the same time, and to some degree, neuropathic pain and neurotrophic keratitis. But our patients are coming in, and it's our job as the eye doctors to figure out where they're actually falling into this. So it's not just as simple as looking at their eye, seeing if there's corneal staining, and asking them if they're having any symptoms. We have to try to understand what risk factors are involved, when their symptoms are more aggravated, the proportional amount of symptoms that they're having in relation to their signs as well. And then I'll leave you with this here. Be kind, for everyone you meet is fighting a hard battle. Whether or not it's someone that has a neuropathic pain, where they're in a chronic pain state ocularly and maybe systemically as well, that is a very hard battle. There's a lot of people that tell them that their pain is not real, even though we can, as eye doctors, see objective evidence of their pain if you have a confocal microscope. But those patients are really suffering and their quality of life is impaired. If they have a neurotrophic keratitis, same thing. They're in less pain, but oftentimes their vision's very blurry and they're struggling to get their vision under control. Maybe they aren't able to drive anymore because they can't reach that 20/40 with both eyes open. And we see this all the time with neurotrophic keratitis cases. Those patients are also fighting a battle, even though they're having less symptoms of discomfort. These are my references. This is my family of 3, which actually just turned into a family of 5, as I have 4-month-old twins now. So this is Kyle. This is Olivia. And with that, I'll say thank you very much, and let me know if you have any questions.
One last question came in. I'm not sure where we're going to go with this, but someone asked, does LLLT help?
Yeah, I didn't include LLT anywhere on that, but
Mhm.
I mean, LLT is going to help obviously treat the dry eye component to it. The research is early, but fairly convincing that LLT can be helpful. So you're reducing the nociceptive input or the actual dry eye component of their pain. I have not seen any evidence that LLT is helpful for neuropathic pain. Perhaps it is, but I have not seen that evidence or seen any papers published on that. I mean, we're just now starting to get papers published on LLT for dry eye. So my guess is, it's going to take a little bit of time for that to be studied in neuropathic pain.
I know they were looking at low level light therapy, LLT was, I think is what it is, for like post-herpetic neuralgia. So I haven't seen
really?
I haven't seen the outcomes of it though. So I know that they were looking at it. That's the only comment I want to make because it's in my herpes lecture.
Yeah. That's
but I
great.
have to go see if there's any follow-up on it.
That's great. I mean, these patients need help. So offering them any treatment that could possibly get them even, 10, 15, 20% improvement in pain is a big deal in quality of life to them.
And I know CBD was kind of out there too. They were looking at that for that. So that's a whole other kind of,
Yeah.
we could talk about that.
I'm in Colorado and I have not really heard CBD for that, although I have many patients that use recreational drugs for pain all the time.
Well, they're getting the THC out there with the CBD
Yeah.
where you are. We were
Yeah.
just talking CBD here.
Yeah.
So with that being said, I put up the sharing slides. If you guys look, I know it's not glaucoma, but we're using that as the background. But you have that little red circle there if you want to start that survey so you don't have to wait for the post-event email to come out in 9 minutes. But we did hear differentiating dry eye from trigeminal pathologies. Joe, any other questions rolling in here?
I think one last one was asking about what about the Bell's palsy patients?
I mean, I've found Bell's palsy is more associated with just, lag ophthalmos and exposure keratopathy,
Right.
and more that's a driver of their symptoms through dry eye, not necessarily through a neuropathic type feature. But I have seen Bell's palsy patients that get chronic exposure keratopathy that's not adequately treated that turns into a neurotrophic keratitis. So
Mhm.
I've definitely seen that, but I have not found that it's associated with neuropathic pain, but it is associated with horrible dry eye from exposure and neurotrophic keratitis.
So just to, just to recap, remember the Bell's palsy is not trigeminal number 5. What is it? Number 7, the
Facial.
facial nerve. So you're
Mhm.
not getting the muscle
Oh yeah,
tone as opposed to that. But, so that's a
that's a good point.
different nerve, right? The facial nerve that has been, blocked, not allowing the muscles to move, now kind of leading to a dry eye and exposure and so on and so forth. And we focused on cranial nerve number 5 here, the trigeminal nerve. So, but could be indirectly. Great question. But just trying to separate the two nerves, we were focusing really on kind of that, I guess, rewiring. It's, if you want to say, of that trigeminal nerve, whether it's functioning properly, whether it's overstimulated, or whether it's now downregulated. And that would be your neuropathic versus your neurotrophic versus working properly. And then kind of the, the outcomes whenever it's, maybe inflamed for a long period of time or not being treated for the, maybe say properly or not early enough. So anything else, Joe?
I think we're good.
Okay. Kaleb, obviously you could tell I enjoyed it. I was geeking out, lecturing kind of opioids and kind of following all this pathophysiology and mechanism. So, I want to say thank you for doing this for OEC tonight, taking something that's pretty deep in science, but then applying that clinical level to it. And you did a wonderful job at it. So I just want to say thank you. I'll turn it over to Joe for some comments.
Of course,
Same
appreciate
thing,
that.
Caleb. I think it was terrific. I think it gave our audience things to think about. It gave me some things to think about. When you think about some other patients that I could probably address a little bit differently. So I think everybody got a lot out of this. So really, thank you. This was very, very high level and clinically applicable.
Thanks, Joe. Appreciate that.
All right, so that will conclude, because there's no other questions, differentiating dry eye from trigeminal pathologies, insights into discrepancies between signs and symptoms. Very well done here with a synchronous virtual course. Again, Kaleb, thank you for doing this for us.